Welcome to Women Don't Do That, where we empower you with inspiration, knowledge, and skills to redefine your boundaries and unleash your potential. I'm Stephanie Minton, founder and CEO of Beacon North Strategies and your guide. Small town girl turned CEO while navigating career, motherhood, ADHD, and chronic migraines. Our conversations range from interviews with visionary women to solo episodes filled with actionable insights. We are your hub for turning what ifs into let's go. Are you ready to redefine your possible? Let's get started. Welcome to today's podcast episode featuring Dr. Elizabeth Leroux, a distinguished neurologist and headache specialist currently practicing at the Brunswick Medical Center Glen Neuro. She also serves as a faculty lecturer in McGill's neurology department and is the founder and chair of Migraine Canada, as well as the former president of the Canadian Headache Society. As someone who personally suffers from chronic migraines, I am thrilled to bring you this interview. Whether you experience migraines yourself, suspect you might, or care for someone who does, this episode is crucial. We'll discuss how to seek help, the latest insights into this debilitating condition, and its profound impact on life. I promise you'll come away with new knowledge that could change your understanding of migraines for yourself or for someone you love. Listen now to learn more. Welcome, Liz.
Hello, thank you for having me.
I'm so excited to have you here today. You don't know this, but I first learned about you from an interview you did about migraine on TVO in 2020.
Oh, during the pandemic.
Yes, it was such a good interview because it really gave the basis around like what migraine is and what it wasn't. And I was either being diagnosed around that time or had just been, and I sent it to like my mother-in-law, my mom, my husband. I was like, you all need to listen to this because everybody has so many preconceived notions about what it is and what it isn't. And it's a hard thing to walk through. And I found that interview just so informative.
Well, I'm glad it could help you. And this experience, by the way, is a very common one that people who don't live with migraine have difficulty imagining what it is. And it's somehow good to have like another person talking about it, just to say it's not only me, like I'm not crazy. Yeah.
Yes, absolutely. Before we jump into some specifics around migraine, I'd love to get to know you a little bit more. What does life look like for you right now?
So at present time, I live in Montreal. It's where I was born and raised and where I did my medical training. I love Montreal. I've lived in other cities, Paris, London. I've seen many in the States, but I love my city and my community. I am single. I've ever been single. I don't have kids either. And I have 3 adorable and very smart nieces that I love. And I do live with 2 cats in my home, so that they are really important to me. So I work as a neurologist and headache specialist, but also as a patient advocate, and I'm the chair of Migraine Canada, so which means I do a fair bit of volunteer work. And I also consult for pharmaceutical companies. I would say I have a diverse professional life, which is great. And I love, so I try to keep a balanced lifestyle now after
Right.
years of being burnt out and working too much. So
Yes.
I practice boxing on a regular basis, and I like to do some singing and jazz and music stuff. So I'm in a good
Oh,
place in my life at present time, but it took
I
me a while to find this balance.
yes, I love that. I hear that from a lot of women, even myself. My kids are now a little bit older and I'm approaching 40. And it's not till now that I've had the time to even realize like how much I've overworked or the balance I didn't have over the last little bit. And so I feel like I'm an early recovering workaholic.
Yeah, yeah. I think society tells us to work quite a bit, but the more I work in neurology and also with migraine patients, the more I realize that we are animals, we are organic beings. We're not computers. So
No.
just sitting and looking at a screen all day long and making decisions, it's not what humans are. So we need to take care of all the other bits.
Yes, that's a very good point. What motivates you to live your best life?
So it's an interesting question because you could say the answer to this would be to help my people be better, to dedicate myself to my art and
Right.
medicine. But I realize it's what motivates me is overall how I feel.
Mm,
I want to feel happy and good on a day to day. For example, if I were giving my best to my patients but feeling miserable, which was the case over my life a few years ago, I would not keep this lifestyle.
right.
So I want to feel happy, and to do that, you have to find your bits of happiness and what makes you feel. I would say not necessarily happy, like joyful and party like, but I would say peaceful and serene and proud. Um, and so for me, it is really a balance. I love my job. I adore my job. I'm so fortunate to work with people in a one-on-one relationship, with this
Mm,
caring relationship. I love the science that I do, but I also realize that I do need to see my family, see my friends, exercise. So what inspires me to live my best life is to keep this balance, where, because I've known places where I had bad days and my life was not good. So now I feel this happiness, this gratitude for life, and I fully enjoy it. So I think that's what keeps me. I'm saying you're in a good place. Just keep
yes.
going, keep doing this.
Yes. I love that so much, Liz, because that framework works in all parts of your life, right? Whether it's with other people or with your work. And I haven't heard that answer before. So I love it a lot. So you're
Well,
already off to a good start of imparting us with wisdom.
that's good. Well, I worked with a professional coach when I burnt out 10 years ago or 8 years ago. And she asked me a very enlightening question. And she looked at me and she said, "Do you think you can be successful and happy?" And the obvious answer for me at that point was no. I was like, to
Right.
be successful, you have to be miserable. You have to suffer. You have to be sleep deprived. Um, and then I said, like, I don't want to have to say I'm dead busy. I cannot do this. I'm so tired. It's like, this is not the person I want to be. And so this was an eye-opening question for me.
Right. Wow. All right. Let's jump into some migraine stuff here. What is migraine?
So migraine is a neurological disorder. So it means it's not a weakness of character. It's not imaginary. There's a lot of things people perceive migraine as. And a migraine is more than a headache. I think this is a bit of something I repeat a lot, because it is a headache with different characteristics, usually one-sided, usually it can throb a bit, but it comes with other symptoms that come from the brain. And those symptoms are in different categories. They're actually very diverse. So it's mostly hypersensitivity. So your sensory filters don't work. So light, sound, smells, movement, all of this is painful and difficult to tolerate. And then there's all the gastrointestinal stuff. So the brain and the gut are close friends. So people will have nausea, vomiting. And then you have like the pain in the head, but also the pain in the sinuses, and the face, and the neck, and the jaw, depending. And in the end, there's all the brain symptoms related to emotions and cognition. So focusing, concentrating, feeling irritable, feeling exhausted. So and then the aura is another thing of migraine. So people might even lose their vision for half an hour. In more severe cases, they can even lose their speech or lose their sensation and even paralyze. So it's an array. It's like an open buffet of symptoms, right? So you cannot make it easy. You have to listen to who the person in front of you describes, and acknowledging this vast, all those possibilities for a given patient. But at the end, it's a headache plus other symptoms, mostly sensory and gastrointestinal.
So, given the wide range or buffet of symptoms, I love that. Is it difficult to determine that somebody has migraine versus something else is going on?
Well, actually, no, because of all the buffet of symptoms, there are still very clear diagnosis criteria that medical professionals will use. And you can ask 3 questions and determine if someone lives with migraine. So first, you have to exclude another cause of headache. And that's important because there are like 200 plus causes of headache, from a brain tumor to a sinusitis to a tooth problem. So you want to make sure you're dealing with something else than migraine that can be addressed differently. But usually migraine first goes on the long term. It's a chronic disease. It starts
Mm-hmm.
usually young and with repeated and repeated and repeated attacks. So then you just ask the person to describe the attack. And basically, with the symptoms I mentioned, you can make the diagnosis. My point about the other symptoms is that once you know it is migraine, then you need to understand two things. So, what type of migraine is it? And then you dig deeper. And also, who is this person living with migraine? What is this person's, lifestyle, medical profile, psychological profile? So you can propose a tailored plan. So to make a diagnosis, it's not that complicated, but then you have to go beyond if you want to adapt treatment to the person in front of you.
Right. Are there different symptoms for kids? Like, what do you watch for in kids?
So first, I will just disclose that I do not work in pediatrics, but the literature is clear, is that attacks in children can be shorter. So in adults, you want an attack that lasts more than 4 hours. In children, it can be less. And also children tend to have more bilateral, like headache on both sides, not necessarily one side. We don't know exactly where that is. And for children, well, they're little, right? So they cannot necessarily express everything they're going through, but usually the parents will see in their faces. A kid with a migraine will often change color, become a bit whitish, having color under the eyes, and they will stop playing and they will just want to lie down and stay still for a while. And that's when they don't actively throw up, of course, if you have the full-blown attack. So they are a bit different than kids. And I will say that 10% of kids have migraine, live with migraine, and it's underdiagnosed and also undertreated because medical professionals don't like to give drugs to little kids.
Yes.
But at the end of the day, we give drugs for epilepsy to kids, we give drugs for asthma to kids, and we should probably treat a bit more our children with migraine with the drugs that are safe for them and could help.
Right. Thank you. That's really helpful. What are some of the different triggers associated with migraines?
Oh, there's another buffet. So one thing to know about triggers, and by triggers, we mean something that seems to initiate or make the attack happen, is they accumulate. So they combine themselves. And the way we see the migraine brain is that you have a bit of a threshold. So the brain will tolerate a certain load of triggers, but at some point you reach this threshold, which depends on the person and sometimes over different phases of life. And then the attack will occur. So that's why it's so difficult to pinpoint triggers sometimes, but there are tons of categories. Okay, so anything related to the brain. So everything is related to the brain. So it can be sleep status, can be hormonal status, can be emotional status. It can be some foods that will trigger. It can be some medications, and it can be like too much sleep, not enough sleep. Emotions can be good or bad. But usually it's anything that will so for example, skipping meals, being dehydrated. So it's a fine line. And I'll say this to people living with migraine, is that it is true that improving lifestyle or adapting lifestyle can help you with the migraine, like with any disease, really. This is true also for MS or multiple sclerosis, epilepsy, diabetes, obviously, and things like that. So lifestyle has a role to play, but it is not only lifestyle, because if you live with migraine, sometimes you can have the best lifestyle ever, meditate every day, drink 2 liters of water and all, exercise, and you will still be debilitated because you need like pharmacological meds to help you. So it's a fine line. We don't want to blame people because often people with migraine are told, oh, you don't drink enough water, you don't manage your stress, you should avoid chocolate. So it's very stigmatizing, but it is true that lifestyle makes a difference, but to a point.
I kind of laughed when you said the water one, because I've definitely got
Yeah.
that one before.
Oh, everybody does. It's so easy. I think people, it comes from a good place usually. People want to help, but they
Yes.
don't know, and so they will just say what makes the best sense to them and what is easy and non-controversial.
Yes.
And the water piece and the stress piece just come very often.
Right. Is it something that you can see on some kind of medical scan?
So migraine is not visible in any tests that we have in the clinic. It has been analyzed in research, though, with numerous techniques. And by numerous, I mean genetics, chemistry, electrophysiology, which is kind of how how the electricity of the brain works, and also special fMRI, so functional magnetic resonance imaging techniques. So we have solid evidence of the numerous pieces of the migraine puzzle. So we know
Right.
it exists. We know it's very diverse. We know there's a lot going on in the brain during a migraine attack, but we still do not have this test, that we
Right.
could use to tell a person or their employer or their insurance company, yes, this is migraine, and even better, this is severe migraine, right?
You're
So
right.
we're still left with the diaries, the symptoms, and the expertise of the healthcare providers and
Mhm.
the willingness of patient to describe.
Do you think that kind of technology is coming?
Honestly, I don't think so. I think it could be coming, but in subgroups of migraine. My
Yes.
personal professional opinion is that the migraine word is, I'll go back to this buffet, is a word that is too vast as a scope. I believe there are subgroups of people,
Yes.
but we're not there yet to kind of put people in categories effectively, because you want to put categories that help you to treat people ideally. We're getting closer to this. So maybe in the future, we'll have some elements of tests for subgroups, but
Yes.
migraine in general at present time, I don't see that happening. There are too many genes, too many mechanisms, too many triggers, too many sets of symptoms to put everybody in the same bag and just have a red
Yes.
stamp and say migraine or not migraine. I think that's a bit an
Yes.
illusion to think that we'll succeed in that.
Right. I think that's such a good point. I can share as a migraine sufferer that I think one of the most challenging things on the mental health side of it is because everybody's triggers are so different, everybody's symptoms are so different, and everybody's treatments are so different that you might find someone who has migraine and can, identify and recognize, that you're both suffering from that and how hard it is, but their experience could be completely different than yours. And so that makes it really hard because it can feel quite lonely.
Yeah, it is very paradoxical that something as common, because migraine is like the third most common disorder in the world, according to the World Health Organization, which is
Right.
like a very official institution. Um, but a lot of my patients will tell me that they feel lonely and isolated.
Yes.
And they feel lonely and isolated because first their families and networks do not understand. But as you say, when they meet someone with migraine, this person is likely similar on a few points, but different on many other points. And I've seen this definitely with the chronic migraine community,
Hmm.
where when they hear about people who live with migraine once in a while and they respond very well to medications, then they don't identify because they say, well, for you, migraine is not a big issue, but for me, it is. And
Right.
on the reverse, for some people who have occasional migraine, when they go to migraine groups and they see people who've tried 10 things and are on disability, they say, oh my God, this is very scary, right? I don't identify like this. So what I recommend and what I hope to develop with my work with the Migraine Canada is an inclusive approach to say, okay,
Mm.
let's focus on migraine as a disease, but acknowledge its diversity and try to address everyone's needs, and
Mm.
not say, oh, I'm worse or I'm better, or like we should work on my subgroup first. So we all acknowledge that the treatments can be effective for different people, and let's try to work as a team and as a group instead of saying that we're so different one from another. And I think that
Hmm.
applies to humanity in general.
Yes. Yes. Yeah. Speaking, like diving in a little bit on the mental health piece, I think one of the challenges that I've had is even just accepting that you have it, accepting that there's no cure for it, right? It's something that you manage. That's hard to accept. The fact that we only know so much about it, right? So some of it, if you're not a doctor, like even for me, some of it I just still don't understand. And one of my triggers is changes in the barometric pressure. And there's nothing we can do about that. But in my head, I'm like, there's got to be. Why can't we figure it out? It's just like, it gets frustrating. And I was really lucky when I was first diagnosed with chronic migraine. I'm a very high outputs person, high achiever. And my doctor sent me to therapy. And a lot of my therapy was about just learning to accept what's happening to my body, and that I can still do a lot, but it looks different. And it took a while to work through that.
Yeah, it does. And it does for many people.
Mhm.
I think there are many components to that. The first one is that migraine is invisible and you feel the experience, but you don't have, like we said earlier, we don't have this kind of proof, right, of what it is. The comprehension of the mechanisms is still early, and very complex. So
Yeah.
you cannot make your own explanation on what it is, and that's very important to people. And then there's society's view on it. So because society does not endorse it, does not recognize it yet, I think it's going to change. It's difficult because you have to deal with something that is quite disabling, and you have to make
Mhm.
a lot of decisions on a daily basis for something you can see that nobody believes exists and that you do not fully yourself understand.
Yes.
So migraine is very similar to asthma in a way, as sometimes I call it the asthma of the brain, right? The lung reacts to triggers. You have to take acute treatments. You may need preventive treatments. You have triggers and so on. So, but for asthma, nobody contests asthma. People, if you talk about asthma, everybody's, yeah, sure, asthma, this is this and this, and you do this and that, right? So I think this matter of mental health and acceptance and being limited in a way, because we have to be honest as well that we
Mhm.
are limited when we live with migraine. There
Yes.
are limitations, but we have to work around them the best we can.
Yes.
And then acceptance is huge, because when you just fight against yourself all the time, this is so draining. and
Yes.
but it takes time. It's not just a matter of waking up a morning and say, okay, my doctor told me I have chronic migraine and I think I'm gonna have to do this and this and that, and I fully accept it and live at peace.
Yeah.
Humans, once again, we are animals of time and patience, and it takes a bit of time to move through this process. But when it's
Mhm.
done, then I've seen people move from a very difficult place to a much better place.
Yes. No, I think that's really helpful. I found for me, I now that my chronic migraines are under significant treatment, I find it a lot more manageable. But then I do find that if I kind of slip into a place where I'm having really bad migraine and, maybe it lasts for a few days or something, I quite easily get very depressed about it because it's so hard. And um if people don't know that are listening, like if you have a very bad migraine and you've taken all your medications, you're in so much pain, but there's nothing you can do. Like there's nothing you can do to make it better. And there are definitely moments where I have been in so much pain. I wouldn't have hurt myself, but if someone had to come in and said, do you want me to shoot you? I think I would have said yes. Like it's so painful. I can't even describe it.
Yeah, the multi-day attacks, I call them blocks, but the
Yeah.
official term is status migrainosus in like old Latin. Um, and it's tough to go through a block, especially, and you mentioned that now you are doing better. So I see people who are used to live in deep chronic migraine every day but
Mhm.
then they get better and they have good stretches where they're doing well.
Yes.
But then when they have an attack, it's somehow even worse because they know
Yes.
what it is to feel well. And then you fall back down in those multi-day attacks where, as you say, you take drugs, you hope for a relief, and it's like you wake up with the migraine. So all of this is very difficult. And once again, you go back to sometimes a lack of support that people, may that be your family, and that there's research demonstrating that partners of people with migraine do not necessarily understand. and employers also. So yeah, it's definitely a tough disease to live with, but I think the only way to go beyond like the guilt and shame and isolation is to talk about it and say, well, I'm living with this. And I think now it's actually happening. Now we have new treatments, and there's more
Yes.
research and science on it, that people feel a little bit better, because we've broken those first few bricks and walls, right? That in the 70s it was still fully psychological and all about, and I'm not even talking about the gender biases and the,
Right.
all the bad words about, like the bad jokes about migraine and women and so on. So yeah, no, we're moving forward.
Yes, I would say from my perspective, in case it helps anybody listening, those days when the migraines are like that, the ones that I described, there's not a lot you can do about it. Right? Like if the light's bothering you, if you're gonna throw up if you move, like you just have to wait for the passage of time, which is very, very hard. So any days that I'm not like that, that I can somewhat function, I do try to keep going, because otherwise, if I let myself into it, I'm just going to lay there. And so I try to decipher, like, when do I have the capacity to kind of keep going and give myself more meaning, versus when is my body really saying you need to take care of yourself right now exclusively?
Yeah, that's another difficult balance, because my patients tell me the same thing, that they say, well, I have to go to work. I have to do things. I'm not going to just spend 5 days in bed. I can't. And it's true that it's not always helpful, because then you don't sleep and then it's worse. So yeah, it's a difficult balance and act on many aspects. And that's why when you find ways as a physician to help your patient to say, well, now those blocks don't happen anymore, or now like they're shorter or less intense, um,
Yes.
then people are usually extremely happy and grateful, and then they go to their lives and they do their stuff, right? So that's the other thing. Sometimes people will judge people with migraine and say, well, all those attacks, it's because you don't want to work, you don't want to do this, you don't want to do that. But I've seen people like missing on their holidays, missing on their family events, missing time with their children or their partners or their friends.
Yes.
And they will chop everything before they chop the work. That's what I've seen.
Yes.
They will say, well, no more dinner for me, no more restaurant for me, no more weekends for me. And then when it starts to show in the workplace, then that's usually a bad sign, because
Right.
people with migraine will awful try to hide it the best they can, because once again of this social stigma that there is on it.
Right.
So if you think about it, someone with epilepsy, I don't want to make undue comparisons, but someone with epilepsy and has, let's say, 2 seizures a year, and I'm not diminishing a seizure importance at all, but if you have 2 seizures a year and you say you have epilepsy, everybody's like, oh, you have epilepsy. Everybody knows about epilepsy. And that's, oh, it's a neurological thing. Oh my God, it's terrible. Did you rest and all that? And that's 2 episodes per year. So if you have chronic migraine and you have 20 episodes per month that are disabling, um, that's just like, that's very severe. But
Yeah.
you do not get this recognition, partly because of the old time stigma and partly because of the lack of a biomarker.
Yeah. And because it's happening so much to you too, you're not going to say to like people, 4 times a week that you don't feel well. You just keep moving, right? Unless it's really bad where you have to be out of the light and stuff. People don't know. And I think even just for myself, sometimes a way to make it through it sometimes is to pretend it's not happening,
Yeah.
because if you give in to it, it's really hard. I find the hardest is if you're trying to work when you have the nausea. That one really gets me. Like that.
Yeah.
That's really
Yeah,
tough.
there's nothing fun. I think now that we have treatments that are quite effective, so I'm naming like the CGRP antibodies and the Botox and the G-pants are coming now, and all of this you can find on our Migraine Canada's website and our YouTube channel, and Migraine Tree reference. So all of these allow me as a professional, when people come back to me and they respond to one of those treatments, and they just realize how well they are doing.
Right.
And it's interesting because it's like seeing like a photo in black, like a negative view. So they come and they say, oh my God, I had forgotten what feeling well meant.
Right. Yes.
And they realized fully that they had to just, like you say, just ignore the symptoms and just push through. And it's funny, one of my patients told me, that she comes from a migraine family, and that her grandmother used to say, well, you have migraines, suck it up, buttercup.
Yes.
And it was just, sometimes you learn this from your family even.
Yes.
Then when you get better, you realize that, oh my God, you mean I can go out? Like I can see my friends, I can
Yes.
train, I can have this bike ride that I haven't been able to do for years because of the light and of the heat, and also. So yeah, it's very interesting to see, and sometimes it's a bit heartbreaking because I see women in their 60s who try one of these meds, and when they get better, there's this moment past, like, oh, I'm super happy, where they have this thought, what if my life, what if I had had this drug in my 20s, my 30s, my 40s, and
Yeah.
all the time lost. But then usually they just shake up and say, okay, let's not go there. Now I'm better. It just
Right.
tells you how difficult it is to live with this disease.
Yes. So for treatment options, that's another challenge because from like we talked about before, there's a buffet of all kinds of things. So from what I understand, it's kind of there's a range of different options, and then it's like trial and error of like what works best for that person. Is that correct?
Yeah, it is. So we have another buffet here. So and it's great because there's more options now than ever. And there's different types of options, like I mentioned, the lifestyle adjustments. And the
Yes.
way I go at this usually is I promote lifestyle adjustments as good for your brain health and your body health in general.
Right.
So
Healthy for anybody.
it's healthy for anybody, but as a person with migraine, well, maybe it could give you even more benefits. So we start usually there. But then there's so many different things from acute therapy. So we have a lot of ways to break an attack, and that can be pills, but that can be also neuromodulating devices. It can be techniques, it can be essential, like different things. Then we go to preventives, and preventives are when you're trying to decrease your migraine frequency and intensity.
Mhm.
And once again, all those, you have different classes of meds. You have neuromodulation devices, you have supplements, natural supplements, and you can combine all of those. And now if I make the list, like we have a full page on all the options on our website at Migraine Canada. Well, the list is quite long, so you
Right.
need a healthcare provider to guide you, because people will ask me, what's the best therapy for migraine ever? There's no answer to that.
Right.
And so you have to try, and this trial and error is not easy, but now we have more options that are likely to be successful, and probably more coming over the next few years, now that we understand better how to do research on migraine. And that's another
Right.
big piece, right?
Right.
So because there's no treatments if there's no research, and there's no research if there's no funding. So
Yes.
it's all those things that people are not necessarily aware of.
Right.
Having healthcare providers that are educated.
Right.
If you meet a doctor and this doctor never had training about options, he's not going to be, or he or she is not going to be able to give you the education and the information you need.
Right.
So I think there's a lot of work to be done, but overall, it's definitely better than, in the 90s, before the triptans arrived, before
Right.
Botox arrived, before antibodies and G-pants arrived. There was not much.
Right.
Not much. It was like potato slices and kind of push through mentality.
Right. So one that people have a lot of interest in and that I have is the Botox. Can you explain how that works? Because people often ask me, I'm like, I don't really know. It's hard
Yeah.
to.
So I will absolutely. So I will recommend first, if you want to have a primer on this, you can go on our Migraine Canada PDF resource. And we have we have 2-page PDFs on many different things.
Okay.
So we have one on Botox, and I'm happy to send you the exact link. But roughly, the Botox story was interesting. It was found by serendipity in women who got it for cosmetic reasons in the 80s.
Right.
And they just noticed these women in their 40s, 50s, 60s. So they were the crowd who has chronic migraine,
Right.
that somehow they had less migraine. So anyway, fast forward 20 years later, now we know that Botox it's not an effect on the muscle, it's an effect on the sensory nerves. And we just quiet down the sensory nerves by chopping their ability to release those little inflammatory peptides around themselves. So nerves are not only electrical wires, they have very active chemical activity. And so if they release the little peptides, then they can irritate themselves. And that's part of when people with migraines say that their hair is painful, everything is painful, it's because the sensory nerves are irritated. So that's what Botox does. And so it's actually a very safe thing because it's very local. It does not interact with any meds. It's been used for decades for all kinds of disorders. It's been used for migraines since quite a bit. And so it is a very valuable thing. This being said, it is for chronic migraine only at present time. So if you have less than 15 days per month, your insurance is not going to cover it.
Right.
And you also need to find a Botox injector.
Yes.
Injecting Botox is super easy. It's not difficult. It's not dangerous at all. But it's all a matter of billing and finding a way to fit it in your practice and
Right.
getting the expertise and the system running. So it's not across Canada coverage for Botox. Finding Botox injectors is not easy. And it varies a lot between provinces. So I encourage people to ask about it if they're interested. But just be aware that there's all kinds of kind of logistical challenges with getting Botox.
Right. So when if you think you're having migraines, when should you see a doctor, like a GP?
Well, that's a good question. We have to if you look at the whole crowd, let's say 12% of the population lives with migraine. That's what the research tells us.
Right.
There's maybe, a good part of these people don't have chronic migraine. They have occasional migraine attacks, and they might have just a few per month or a few per year. So that's what we call low frequency migraine. And sometimes those people will just actually have mild attacks. They can take over-the-counter medications, and then they take ibuprofen, aspirin, and espresso, they rest, and that's it. And maybe these people don't need a lot of medical support. But if you do have attacks that stop you in your tracks, and then you cannot do what you wanted to do on that day, and you feel, you have attacks that come back and again, and it's having an impact on how you work and function,
Right.
then at least you will need a good acute treatment. If you have frequent attacks, and that varies for people, it can be 2 or 3 per month, can be already a lot. But if you go to 4, 6, 8, 10, 12, then the impact becomes severe. And if you move toward this kind of 50% of your time migraine, which is chronic migraine, the bad word by the way, because all migraine is chronic. A chronic disease is over a lifetime. So all migraine is chronic. We chose this word years ago, but let's say, frequent and disabling migraine. Some people call it resistant migraine. Anyway, we still have work to do in the wording. Well, then obviously you need a doctor. So I would suggest, if migraine bugs you, like if you're losing your days to it, just seek medical advice and start with the basics, finding a good acute treatment, and then consider prevention if the attacks are frequent enough that they are impacting your life.
The game changer for me was really when I got to see a neurologist. So when do you need to see a neurologist versus just a GP?
So in an ideal world, because migraine is so frequent, there's tons of people with migraine. In Canada, we think that 1 household over 4 has a person with migraine in it. That's a lot of people. So GPs should probably be able to manage the majority of people with migraine, that is prescribing basic medications, giving basic advice, having the diaries going, starting preventives. In real life, in Canada and in certain provinces, it's worse than others. GPs are totally overloaded. They are undertrained in migraine management, and they don't have the time to provide the much important education and information that patients need.
Right.
So that's why so many people ask to see a neurologist, because they don't feel that they're getting what they need with their primary care provider.
Yes, I hear that a lot.
Yeah. So I think the ideal, and that's what we are working on at Migraine Quebec, Migraine Canada, and me personally in my networks. I think we need to clarify to have more allies. We need a team. So the pharmacist can be part of your team. Ideally, in primary care, there would be nurses to give the migraine education. And then GPs would mostly, prescribe the medications and give some pharmacological advice. And the headache specialist would see people, like in Quebec, we have rules to see a specialist. So you need to have tried at least 2 triptans and 2 preventives. We expect GPs to do that. Let me tell you, it's not done. And people come to me, and sometimes they have had the prescriptions, but not the information.
Right.
And that's part, we call that therapeutic education.
Yes, I think that's probably quite true, Liz.
Yeah, so that's the therapeutic education is actually recognized by the World Health Organization as an essential part of chronic disease management.
Okay.
But then migraine is not recognized as a chronic disease in Canada.
So why?
Because I don't know why, but I think because nobody asked, nobody pushed. Obesity has been recognized as a chronic disease in Canada as of last year, if I'm not mistaken. So now we at Migraine Canada, we really want to start understanding how we can make migraine a chronic disease in Canada. So we develop those resources for people on a wide scale.
Right.
Because in theory, you shouldn't need a neurologist or a headache specialist if you deal with episodic migraine and you haven't tried much. But then there's a huge gap in primary care.
Right.
So anyway, so there's a lot of stuff in education, logistics, politics.
Well, Liz, maybe we should talk offline about it because I'm a federal lobbyist.
No, I know, and we definitely work on all of these aspects. But I think it's important for people to understand why the waiting lists are so long, why doctors don't know, why they're not getting what they need.
Yes.
And then we can, strategize and make things change.
We're running out of time, but I do want to ask some really quick questions. Maybe if you can try and answer them fairly quickly. For work, from what I understand, 50% of people with chronic migraine don't work. Is that true?
So there's different studies, but it's true to say that I'm not sure about the 50% data, but a fair percent of people with chronic migraine are all either on long-term disability, short-term disability, part-time work, or restricted in their ability to work. That's very true.
So do you have any advice for people who need to work with their work on accommodations?
Yes. So and we're working on that with Migraine Canada too. So the first step, I think, is to have an open conversation with your HR or employer and to make sure that they understand what migraine is. And that's what we want to develop. At present time, we do not have Canadian resources, but the Migraine at Work website on the US is excellent. There's a lot of stuff for employers out there.
Okay.
So first is to make sure that your employer gets it, because if they think migraine is just a little thing, you're making it up, it's never going to go well.
Right.
Then you need to get your doctor on board. I do this on a regular basis. Sometimes just a little letter saying this patient has chronic migraine. Chronic migraine is la la yada yada, and we are trying treatments, and this patient is resilient and trying the best they can. So that sometimes will just make the employer understand.
Right.
And then sometimes we have to ask accommodations. There are numerous accommodations. Again, the letter from the doctor usually is very helpful.
Yes, I'm sure.
It can be, lighting, can be scheduling, can be flexibility, can be hybrid work, can be screen adjustment, can be a lot of stuff. And then once you enter disability, may that be short-term or long-term, once again, we fill a lot of forms to try to explain why the work is not possible. But we have investigated this at Migraine Canada, and the migraine is not recognized as a legitimate cause for disability by most programs. And this is also the case in other countries, by the way. So you have to understand the employer's view is that because there's no test and there's no proof and there's no biomarker,
right?
In theory, anybody could just fake a diary, fake a questionnaire, and say, I have chronic migraine and please pay me disability, right?
Right.
So it could happen. So if you take it from their perspective,
right.
as a doctor, I see people, I listen to them, I believe them, I know, but so that's their big problem with the long-term disability, is that migraine, there's no absolute biomarker for it.
Right.
But once again, that's your doctor can assist you with that usually.
Okay, thank you. How does it change over time for women? Like, does pregnancy change it, or menopause? Like, how does that factor in?
Yeah, so the hormonal aspects, and if people are interested by that, we have, I think now 2 webinars on hormones on our YouTube at Migraine Canada. So with
Okay.
experts that are really in depth about this. And you can explore also the branch on the women and children from the migraine tree. So we have pages on this. But roughly put, hormonal levels influence, especially estrogen levels influence migraine. So some women have menstrual migraine, which is very difficult to treat in some people.
I have that.
Yeah, so it's common to have menstrual attacks. I have that too. And so then during pregnancies, 2/3, 3/4 of ladies will get better at the second and third trimester. The first trimester is often all over the place because of the hormone levels are very irregular. And then there's also a myth that menopause cures migraine, which is absolutely not true. We wish it would be.
Yeah.
But yes, some women who are very influenced by hormones get much better after menopause, like drastically better. But that's not everybody. That's not even the majority, actually. And a fair amount of people will get worse, of women will get worse before menopause. And some even after menopause will be worse than they were before. So and then I'm not even talking about, the use of contraception, hormonal replacement therapy that can influence migraine attacks. So the key message here is that whatever you're doing, yes, if you have hormonal cycles, it can influence in all kind of directions, and you need to discuss this with your healthcare providers because there's a
Okay.
lot of things that can be done.
Okay, thank you. I want to end with a question that one of our listeners sent in around this topic, and then we can do our rapid fire questions. And they want to know if you have any advice around managing guilt when it comes to migraines, like not being at work or not being able to be with your kids, not walking their dogs, just having a really hard time with that.
I'm glad you bring this up, Stephanie, because it's common. It's very common. And this guilt and shame feeling is ingrained in us. And I will say that women are, we're well geared to develop guilt and shame from education in the society. My advice, and I know you cannot just tell yourself, don't feel guilty. That doesn't work.
Right.
So how can you modulate this? Well, you have to kind of exercise your ability for self-compassion.
Yes.
And this is done through, I recommend a regular practice of meditation for self-compassion and gratitude.
Mhm.
And very often at the beginning, when I suggest this, I see a lot of pushback. People are angry, but the anger comes from a place of suffering usually.
Right.
So you just say it's like you practice an instrument and you want to play differently. It's not going to happen just with a snap that you tell yourself, from now on, I'm like this. So you go on the mat and for 5 minutes, you do a breathing exercise and you find there's tons of self-compassion and gratitude meditations out there, and go there and study what happens. And if you say, I can do this, I'm very angry, I cannot tolerate this, then it means you should do it. It means
Right.
you should push through, breathe, and explore those feelings. Let them be. Acknowledge that there's a very good reason why you feel this guilt. And so try. If exercises at home are just like maybe some book reading, some time doesn't do, then you can seek therapy. And I've sent a lot of patients to ACT. ACT is acceptance commitment therapy. It's a special type of cognitive behavioral therapy that's very good for chronic pain. So ACT, and work on it. But gentleness and kindness is something you have to cultivate. Our world is not around gentleness and kindness.
Yes.
Series are all about people raping and killing each other. Succession, for example, everybody talks about this series of Succession, which is maybe a very good series, but it's all about mean people fighting for power and control, when we should really try to see how we can be gentle and kind. And that's something that needs regular work, one
Yes.
step at a time.
Yes. Thank you for that. What is the best rule you ever broke?
Well, this one is clear for me. It's that I left academia. I left the academic hospital.
Right.
I was trained as a young doctor. I spent 5 years in med school, 5 years in neurology training. And when you're trained in an academic hospital where there are teachers and university and all that, and you're taught that it is the best place to be ever, and this is the only way to live a worthy life as a doctor. But after 7 years of practice there in a stigmatized area, which is headache medicine, I was crushed, completely disheartened. I was crying on my way to work most mornings. It was really tough. But medicine is tough. People will tell you, you just suck it up, buttercup, again, right? It's difficult, but it's the way. It's normal not to sleep. It's normal not to eat. It's normal to feel crappy. It's normal to be alone all the time. And so at some point I had an epiphany, and I said, why am I staying there?
Right.
And I said I could leave. And then I actually sought professional help with professional coaching. And I worked with a woman called Minda, who's my coach. She's really helpful. And then I realized all those things, and I said, you know what, I'm leaving.
Yeah.
And then I moved to Calgary for 2 years. In the end, it didn't work. This is not what I wanted. And now I have this nice life where I could feel guilt that I'm not working as hard as some of my colleagues. I sleep at
Right.
night. I don't take call. But I do follow patients who need all my attention, all my compassion. And if I'm exhausted, I cannot treat these people.
Mhm.
So far, this was a very big move for me. And I'm
Okay.
not saying to everybody, like, leave academia. That's not my point. But I think if you are really unhappy in a place, you have to wonder why.
Yes.
And maybe there's a better place for you somewhere else.
I think many of our listeners will want you as their doctor. Can you
Yeah,
name
well,
another woman that inspires you?
yeah. So one is Jane Goodall. So the lady who did the research on the chimpanzees. I saw her giving a talk recently at 89 years old, passionate. And I didn't know this, but she was a young woman from England who moved to, went to Africa with no training, and just went into the jungle. At the time, she couldn't go alone because she was a woman, and the British embassy didn't want any young British woman lost in the African jungle, right?
Right.
So her mother came with her, and she spent
Wow.
6 months in the jungle with her mother. It was just crazy. And then she faced all the scientists that had training in Oxford and Cambridge. And she was told that, she was wrong, and that all that she observed was wrong. But she persisted, and obviously, she was right. She observed with an open heart and an open mind, and she made very, very strong breakthrough in the science. And then she moved to be an advocate for community and ecological work, which is
Yes.
something very dear to me. I'm a bit of an eco-feminist, right? So I believe that there's something in what we call a woman view, but I don't want to genderize it, but I think we should just look less at greed and power and accumulation, and more at respect, sustainability, kindness, simplicity. So that's one. And another, well, obviously my mother and grandmother, who were autonomous women and very open-minded and very generous. My mom is always like, how can I help someone around me? Can I
Yes, my
bring
mom
food to
too.
my neighbor, right? How can I make the world a better place? And very anchored in simple things. Just cooking food for the people you love is
Yes.
great.
I'm gonna jump in
And
with you, Liz, because I have two more quick
no,
questions and we're running
sorry,
out of
let's
time.
go.
Is there a podcast you're loving right now?
No, I don't listen to podcasts
That's
that
okay.
much. I'm busy. I'll tell you what I listen to.
Okay.
I listen to the Outlander novel series on audiobook,
Okay.
and it is amazingly good. So if anybody's looking for like listening to novels, I listen to Lord of the Rings, Sherlock Holmes, Agatha Christie. So this is my
Nice.
half an hour before bedtime, and I love to listen to people telling stories.
Great. Is there a book that made you wiser?
Probably the work of Yuval Harari. So he wrote Sapiens. And then the third one is the 20 Lessons for the 21st Century. I think he addresses very interesting questions about how humans behave the way they behave and what is the future of humanity in seeking happiness. So
Interesting.
this definitely Yuval Harari. Another one, Anger. We talked about anger. By
Yes.
Thich Nhat Hanh. So Thich Nhat Hanh is a Vietnamese monk who is now deceased, but he ran a Buddhist village in France. And if you are struggling with emotions and anger, you might find some solace in his teachings. He's really great.
Hey, thanks so much, Liz, for being here. It was such a joy to spend time with you.
Absolutely. Thank you for asking all those relevant questions. And I sincerely hope that anybody listening can find a little thing that helps them or help them find them a better life.
Thank you.
Thanks for joining us on Women Don't Do That. Don't forget to subscribe and leave a rating or review. Connect with us on Instagram at Women Don't Do That and visit our website www.womendon'tdothat.com for more details. Join our Patreon to support our work. Find all of the links in the show notes. Remember, you have the power to transform your what ifs into let's go. Together, let's redefine your possible. Until next time.